Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it and sharing it with your near and dears to help them prepare not only for the MBBS course but also for other postgraduate and medical job entrance examinations. Please don't forget to hit the bell icon below so that you never miss useful lectures from us. In this lecture, I will be discussing 10 MCQs on a very important and exam productive topic, hernia. The correct answer in question number 1 is option B. An omentocele is a type of hernia where the omentum protrudes into a hernial sac. This makes it very prone to become irreducible, leading to strangulation and bowel obstruction. Surgical intervention is often required to repair the hernia and prevent complications. Also remember, all cases of femoral hernias also have a high risk of strangulation and therefore should be repaired surgically. An enterocele is not a hernia. It is a kind of a small bowel prolapse in which the small intestine descends into the lower pelvic cavity and creates a bulge in the posterior vaginal wall. The correct answer in question number 2 is option D. Leiter's hernia is a rare clinical entity defined by the presence of Meckel's diverticulum within a hernial sac. Leiter's hernia can present as an inguinal, femoral, or umbilical hernia with symptoms and complications like any other hernia with the small intestine in its contents. The herniating part of the gut can get obstructed, incarcerated, or even strangulated, just like other hernias. Hence, the diagnosis is established only intraoperatively on the exploration of the hernial sac. A Richter's hernia is said to occur when only the antimesenteric border of the bowel wall lies in the hernial sac. Sliding hernia or hernia-en-glissade is defined as any hernia in which the part of the sac is formed by the wall of a viscera. The most common content on the right side is cecum and on the left side is sigmoid colon or the urinary bladder on either side, being covered by the peritoneum on the hernial aspect only. This condition may be associated with a strangulated small intestine within its sac or a strangulated large intestine outside the sac. Medal's hernia is a rare and potentially fatal type of hernia in which two loops of bowels remain in the sac and the connecting loop remains within the abdominal cavity. The loops of the hernia look like a W, giving it the name Hernia-en-W or W-shaped hernia. The central portion of the W loop becomes strangulated first, followed by the loop within the hernial sac. Hence, it is also called retrograde strangulation. The condition is only suspected when there is tenderness above the inguinal ligament together with presence of intestinal obstruction. Slide is 10. The correct answer in question number 3 is option A. A Richter's hernia is said to occur when only the antimesenteric border of the bowel wall lies in the hernial sac. Unlike other hernias, it does not involve the entire loop of the intestine, making it difficult or even impossible to detect clinically. Hence, it may go unnoticed for a long time. Frank bowel obstruction may not occur, but the bowel wall may become necrotic and may perforate due to ischemia. This condition often complicates a femoral hernia and rarely an obturator hernia. Operation is frequently delayed because the clinical features resemble gastroenteritis. The inguinal canal is an oblique intermuscular passage about 4 cm long, lying above the medial half of the inguinal ligament. It extends from deep inguinal ring to the superficial inguinal ring. The superficial inguinal ring is a triangular gap in the aponeurosis of external oblique muscle and lies above and lateral to the pubic crest. The deep inguinal ring is an oval opening in the fascia transversalis and lies about 1.25 cm above the mid-inguinal point. The correct answer in question number 5 is option B. The given image is a plain radiograph of the pelvis. Here there are multiple button-like hyperdense shadows which are spiral tacks used to fix a mesh after a transabdominal preperitoneal repair. These may cause chronic pain or inguinodynia if some nerve gets entrapped. All other options listed are either intraoperative or postoperative complications. The correct answer in question number 6 is option D. Under European Hernia Society classification, the primary hernia is denoted by letter P and the recurrent hernia by letter R. The hernial defect size is recorded as number of finger widths it is across. Here, one finger width represents a defect of 1.5 cm. Hernias arising lateral to the inferior epigastric vessels, that is an indirect hernia, is denoted by letter L, and those medial to these vessels or a direct hernia is denoted by letter M. Femoral hernias are denoted by letter F. Hence, a recurrent, indirect or lateral inguinal hernia of 3 cm defect size will be labeled as RL2. The correct answer in question number 7 is option C. Bassini, Shouldice and Desarda procedures are open suture repair methods for inguinal hernia repair, whereas Lichenstein repair is an open flat mesh repair method. It is a tension-free mesh repair technique. In this, a polypropylene mesh is placed between internal and external oblique muscle layers, eliminating the need to use weak tissues for closure of the hernial defect. The correct answer in question number 8 is option A. A spigelian hernia is an interstitial hernia that arises through a defect in the spigelian fascia. This hernia occurs through the linea semilunaris, typically at or above the arcuate line, that is, a few centimeters above the inguinal ligament. These hernias lie deep to the external oblique aponeurosis. The correct answer in question number 9 is option C. The Lichenstein tension-free mesh repair is done in following steps. Opening of the subcutaneous fat and the scarpa fascia down to the external oblique aponeurosis. Dividing the external oblique aponeurosis, starting from the external ring laterally for up to 5 cm, protecting the ilioinguinal nerve. Mobilizing the superior and inferior flaps of the external oblique aponeurosis while protecting the iliohypogastric nerve to expose the inguinal canal. Mobilizing the spermatic cord along with the cremaster muscle including the ilioinguinal nerve, the genitofemoral nerve and the spermatic vessels, taking care to protect them. Opening of the coverings of the spermatic cord and identification and isolation of the hernia sac. Inversion, division, resection or ligation of the sac as necessary. Placing and fixing the mesh to create a new artificial internal ring. Finally, you close spermatic cord coverings, the external oblique aponeurosis, the subcutaneous tissue and the skin. The correct answer in question number 10 is option D. The incisional hernia repair is a significant challenge in surgery. Recurrence is a difficult problem, particularly after suture repair. Primary suture repair has been shown to have poor results, with recurrence rates of 15% to 50%, which is very high.